morning, everyone. It's been 1 year that we started our research project on pediatric viral infections, characterization of novel infections, and child-friendly approaches. I work at the first department of pediatrics as a resident, but I am also a PhD student doing my research at Center for Translational Medicine. My mission is to give kindness, care, and comfort for our patients, and I really feel that in the future the fact and the sensation of safety will be natural for our patients. So in the last year we set 3 separate goals for ourselves. The first is to clinically assess children with long COVID syndrome, to move our data to a more professional platform, and to start to assess the different methods for preventing influenza for children. So our first project started in March 2021, when long COVID was really new, but it is still a complex entity with a great impact on children's everyday lives. Still, there is no clear guidance for pediatric clinical management, so that's why we thought that with our systematic and detailed study with medical assessment findings could aid the process of creating evidence-based guidelines. Our hypothesis was that the characteristics of these clinical findings will be diverse and their amount will be low. So I could only tell you a few results in lack of much time. Basically, it was an average 18% of all cases when we could diagnose clinically important connected results to symptoms, mostly pulmonary symptoms, and in 7% of all cases we could also diagnose autoimmune thyroiditis. But we could assess their symptoms characteristics, their quality of life changes during our research. Our main strength was the in-person multidisciplinary assessment, and our biggest limitation is the lack of a control group. Our main conclusion is that symptom-related conditions were only detected in a minority, but based on our results, thyroid screening should remain in future guidelines. Also, controlled studies are essential in reducing the vast amount of checkups we should do in these children. I can cheerfully present that our first project was accepted in pediatric research in June. Our second project started in the meanwhile because we needed a more professional platform for our data collection and storage, so we needed to create and also to move our vast amount of data to this new platform, which is the REDCap system. And we created it, and it's more efficient than Google Forms. And apart from COVID, we also started to investigate the differences in the 2 available vaccination forms in prevention of influenza, which is the inactivated intramuscular form, and the other one is the nasal live form. We all know that prevention is the main prevention is available, and the main form of it is vaccination and to achieve herd immunity. So it would be really good to establish especially child-focused national vaccination strategies, as it is presumed by mathematical models that with 90% coverage of children vaccinated could decrease the incidence of influenza by 2/3, and also by 80% in the most vulnerable elderly. But recommendations at this moment do not favor any particular type, so if we would like to establish this new strategy, the vaccination of choice not only has to be efficient, safe, cost-effective, but also appealing for our patients, as this is a vaccination of choice. And according to Center for Disease Control's results, vaccinations are not administered in line with the recommendations in up to 25% of children. So in our study, we only used randomized active controlled trials, and our main outcome was laboratory confirmed influenza after vaccination, and our hypothesis is non-inferiority. So after a systematic search and selection, we had 27 articles for a qualitative synthesis and 24 for quantitative synthesis. We did a vast amount of analysis with 44 different subgroup and main analysis, so I only have time to present you our main outcome, which is the laboratory confirmed influenza after vaccination, presented in event, and the pooled results are in odds ratios. If you see, our pooled results are mainly on the left side. Our first main analysis in the first line, and you can see that the nasal influenza vaccination form presented to be significantly more efficacious in decreasing laboratory confirmed influenza after vaccination. But we also saw a high heterogeneity, that's why we also performed several subgroup analyses, and you can see the same result for studies performed in more than 100 centers, and it's also seeable that it seems to be the most effective for the youngest age group, which is a conflicting data as it is prohibited for children under the age of 2. We also performed other subgroup analyses as well based on safety, and we can say that it's safe for children, both of them based on related serious adverse events or hospitalizations. And we also performed several more analyses, and the only adverse event which were more prevalent in the nasal group was runny nose. So in summary, our biggest strength is the robust analysis with multiple subgroup analyses, but we also had several limitations. But if we would like to establish a child-focused national vaccination strategy, nasal influenza vaccination could be the preferable form for healthy children aged 2 to 18 years. But we should further investigate children under 2 years old, consecutive years, and children with or without health conditions. We also finished our first draft, and we are about to send it to internal review. So we finished our first 2 projects and in the finish line with the third one. And I count myself as an explorer, and so research means that you don't know, but you are willing to find out. Thank you for your attention, and I'm open for your questions.
Is it the EU and FDA approved nasal vaccination for children?
Yes, it's approved also in Hungary and available since November.
Perfect, thank you very much.
As I am not a pediatrician and I don't remember, to be honest, I'm just curious about the number of, like maybe the prevalence for autoimmune thyroiditis in like general population of the children compared to the result that you have like in COVID-19 infection. Like what is the difference between these two? Thanks.
Thank you for your question. It's really interesting. That's why we really need a control group, because we found an elevated level of autoimmune, so anti-thyroid biomarkers in their levels, and we can't really compare to anything. So this is not the direct answer for your question, but our main question will be in the future, and we are about to analyze it and compare to a controlled group. What are the differences between the anti-thyroid biomarkers in children after COVID and without COVID? Because routinely we don't really examine this, only if we have an elevated TSH level or not, but I don't really remember, sorry, the amount for autoimmune thyroiditis in general.
How do you run your post-COVID clinic? So how frequently you follow up the kids, and what is the way forward?
Thank you very much. So basically, we have an online registration form. Then we send out an online survey, which consists of two different parts of questionnaires for them based on their basic characteristics and acute COVID symptoms and long COVID symptoms with its frequency and quality of life changes. And they come to the first checkup when we discuss these questions, if we need to fix anything in it or not. And then after medical examination, we discuss it with experts if we need to do further examinations or not, like to send them out for lung function tests or EKG or anything which could be needed. And we do a really thorough laboratory test. And then we discussed its results in 1 and 2 weeks when they are ready with our patients if we need to further do anything, because we found in, I think, 10% of all cases we can find differences which are not, so they are really diverse. And then we do online checkups in the 1st, 3rd, 6th, and 12 months. And we discussed to do it after 2 years as well. And if anything happens, we can also do an emergency checkup, and they can come back, and we follow them up for 2 years.
Okay, still one last question. Well understood that this is attenuating living vaccine, this nasal influenza. Is it had any danger for special subgroups where is contraindicated? I think in immunocompromised patients.
Yes, it's prohibited for those who are immunocompromised, and also for those who are taking aspirin routinely because of the risk of Reyes syndrome.
Mm-hmm. So it would be very important to call the attention of the general population for this, because otherwise it would be a very free access for this. No free access.
It's not really free, and a lot of people are more afraid of using it because of being live, and it's also prohibited for children under 2 years old, but because of only one study examining children under 2 years with elevated risks for hospitalization and wheezing, so they do not let it to use according to our analysis in the age group where it's the most efficient. So it should be revised because it's only based on about 600 patients' data.